Bear with me. And for those that joined on a little late, please drop your name and organization in the chat for attendance. So we are going to move a little bit faster. I know when you go through trainings like this, you're always thinking of a particular child or family that you've worked with over the years. And, you know, we really won't have time during the content delivery to go through those kind of specific anecdotal questions. But I am going to keep this Zoom open for 30 minutes after the session closes. If you do have a specific question or want to follow up on something, we will save some space for that. But being mindful that a lot of people are probably on their lunch break, we're going to get through this content pretty quickly. So for today, I am going to ask you to think a little bit deeper than just trauma's bad for kids. Because I do these types of trainings and I talk a lot about trauma and resilience and trauma-informed care. And I always ask people, why should we be trauma-informed? And it's like, we all know that we should be, but that's a really hard question, it seems, for people to answer when I ask that question of why does it matter? Why should we be trauma-informed? You know, who cares if we're trauma-informed or not? And so we're going to start to kind of think about that a little bit more of, why does this matter? Why is this important? How does this or how should this be impacting the way that we work with children? So we are going to go a little bit deeper than just trauma is bad for kids. We are going to be talking about the adverse childhood experience study, which many of you were probably already familiar with, but now you're even more familiar after having done the pre-reading. But we're going to talk about implications for our practice and our decision-making. We're going to kind of level up a little bit. We are going to talk about the importance of child well-being and kind of elevate the importance of child well-being in our processes, our child welfare, our child serving processes, just in the same way we do safety and permanency. We are going to talk a little bit, not as much as I would like. Unfortunately, I had to keep things pretty narrow, but talking about the impact to future health and how that should be incorporated into the decisions we make today. The other important thing is this is only the very beginning of this conversation. And a lot of you have probably already had similar trainings. My hope is maybe thinking about this from a different angle or something like that. But this really should prompt further learning. You're not, in this 1 hour with me, you're not going to learn everything there is to know about trauma and trauma-informed care. So we're going to start with a video. It's actually a TED Talk. It's actually a TED Med Talk. And it's by Dr. Nadine Burke-Harris. I'm sure many of you have seen her TED Talks or seen her work. You've maybe even seen this particular TED Talk. She did it a couple of years ago. For those of you that don't know, Dr. Burke-Harris is a pediatrician, and she's actually the Surgeon General of California. And she's done some really revolutionary work in community-centered healthcare, and really has helped us actionize all we know about trauma because of the ACEs study. But her TED Talk gives a great overview of the original validity study and then of the Kaiser Permanente work. So I do, as you're watching this video, particularly if you've seen the video before, is to think about my very first question, which is, why should we be trauma informed? And kind of think about that of, what does it mean for the work that we do with kids? How can it influence or affect the work that we do? So that's kind of my challenge to you as you watch the video, because I know some of you have probably seen it before. So here we go. If we have any technical issues, just log back in through the same link. I'm not expecting any, but if we do, log back in through the same link. Similarly, if you can't hear something like that, just send me a chat. And again, if you joined a little late, please drop your name and organization into the chat for attendance.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, "Dr. Burke, have you seen this?" In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you. In the mid-90s,
Okay. So I'm sure some of you have probably already seen that video or have seen some of her other videos, but I really like this one because it explains the background of the study, which was actually the original study was not, Felitti, it was not originally meant to look at trauma. He was actually addressing weight loss in patients and kind of stumbled upon this issue of trauma. And then, of course, then the ACEs study was born. So I like that Dr. Burke-Harris gives a lot of that background in that particular video, and talking about it in clinical terms of, kind of adding doses and what can we do to prevent future doses, right? We can't necessarily erase experiences that young people or children have already had, but what can we do to stop and then kind of heal from that moving forward? So I have two graphics that I want to show you that just, again, conceptualize the ACEs study. And this one is actually from you can look this up, and at the end, you'll all get copies of the slides via email, and as well as links to this resource and others. So don't feel like you have to necessarily write down everything. You'll get it all and it'll be handy for you. So this is from the CDC CASA study, and it kind of talks about the actual mechanism by which ACEs can influence health and well-being throughout the lifespan. So on the right-hand side of the screen, you kind of see you have this trajectory, right, that everyone has from conception to death. And then we see this pyramid shape. And down at the very bottom, we see how these things build and compound. So we start out, right, we have that historical trauma, that generational embodiment. This is where, we think of things like historical racism and how that kind of lays this foundation for future health outcomes. And then we build onto that and we look into kind of social conditions like the local context. So, we know when we look at public health figures in just Ohio, for example, I know many of us are tuning in from Ohio, and we know that, the zip code that you live in or that you were born in can sometimes give us an indicator of what types of treatments or, what your outlook might look like if you were to be diagnosed with a serious illness, just based on where you live. So that's where things like poverty, access, disparity, resource distribution, all those things come in. Then we have, of course, the adverse childhood experiences, that she listed them all off in the video, but abuse, domestic violence, chronic neglect, all of those things going on. And then that leads to that disrupted neurodevelopment that she described. And then from there, we kind of start seeing some of those cognitive impairments, a lot of what we call in our work with children, dysregulated type behaviors. And then from there, we might have start seeing those riskier health behaviors like, using, experimenting with alcohol or drugs, things like that. And then from there we have, disease, disability. And I like that this graphic includes the emergence of social problems. So we start seeing it interferes with relationships. And you all know this, but it creates this cycle, right? Someone is dealing with something internally. They've had a disruption in their emotional regulation, let's say. And that makes, maybe presents in some challenging behaviors, things like that. And then it creates this relationship issue where they're trouble connecting and maintaining relationships with others. So, people might withdraw from them. So then they're losing their support system, and it's kind of reinforcing this. So we kind of have this cycle that goes, and then all the way up to, serious disease and of course, early death, as she mentioned. And then the next that I want to show is early adversity has lots of lasting impacts. And this is also from the CDC Kaiser study. This is a graphic from the CDC or from the National Center on Injury Prevention and Control. But I like this one because it kind of breaks down what this could look like. If someone has we think about adverse childhood experiences and we're thinking about, oh, it's going to lead to a heart attack, or it's going to lead to, post-traumatic stress or post-traumatic stress disorder. It's going to lead to cancer. But I like that this graphic kind of breaks these things down. We might have unintended pregnancies, a higher likelihood of having pregnancy complications, infectious diseases, and then we put that together with trouble accessing care, or all of those other kind of social conditions that sometimes can play a part. And then we have maybe even additional doses of trauma being added into the mix. So I like these graphics. Again, you'll get these at the end for your future reference, but I think this is a really good one. This actually is a graphic that I have used with parents before to help them understand when we start talking about, we really don't want to continue to add trauma for your child, and kind of, help parents understand what this can mean and what they can do about it. And it's not to, make them feel terrible about what's happened in the past, but instead saying, okay, moving forward, I think we're all on the same page here. We want your child to grow up healthy, happy, strong, and secure, and well supported. And here's what we can do to prevent future doses. So thinking about the child serving space, I know some of you are CASA, some are child welfare, some are community health providers. I know we had some parents and foster parents signed up as well. So lots of experiences here. But how do ACEs typically impact our decisions and practices in this child serving space? So here are the 4 that I see the most. I see that we kind of, since we started to learn about ACEs in child welfare and social services, we're really starting to explore historical trauma, like the child or the family's historical trauma, as part of that primary fact finding that we do. It definitely impacts, as it should, our recommendations for services like counseling, of course. A lot of times I'm seeing ACEs or trauma being used as a lens to understand behavior. And that might be the parent's behavior. We might have some questions about their childhood in order to help us understand their behavior a little bit better, the decisions that they make. And then likewise, just understanding child behavior. I'm sure many of you have probably had a conversation with a caregiver or a teacher saying, well, the child has experienced X, Y, and Z, which might help us understand and explain why they're behaving this way at school, for example. And then we've also starting to see the implementation of just trauma aware and trauma informed practices. I think that this last one is the place where we have a lot more work to do, because I think there are a lot of trauma informed individuals, but I think our system as a whole needs to be a little more trauma informed. And I think that's the conversation I'm really hopeful we're starting today for you. So things that I often don't see us considering in this child serving space and in the child welfare and juvenile justice space is, how do the decisions that we make today about a child's life today and tomorrow, are we considering the long-term health consequences of those decisions? Are we even thinking about it? Is it even on our mind? And kind of, how do we move beyond just using ACEs as the shorthand for trauma, right? Sometimes we'll say, oh yeah, that child has ACEs. And that's kind of all we say about it. But really thinking about the long-term implications of the situation that is happening today. And what could we do about it? Really thinking about it, taking, 1, 2, 10 steps back and thinking about the child's entire life and how are the decisions that we make today going to impact them in the future. And then, the question I often find myself thinking about, is there some sort of time limit or parameters when we're thinking about a child's best interest? Best interest is a legal term that we use here in the court, but are we thinking about the child's best interest today for the next year, until they're 18, or are we thinking about their best interest for them as a human being indefinitely? And I don't know, I think the jury is probably out on that. So let's consider, should the long-term health of the children we currently serve be a factor in determining best interest? I argue yes, although I know that there's probably a lot of opinions about it. So in the child welfare, juvenile justice, and child serving space, we often are thinking about safety, permanency, and well-being. And then kind of at the center of that is the child. And I would argue that our child welfare system, like our child protection systems and our juvenile court systems are really good at keeping kids safe. That's what they're designed for. That's the entire mechanism. We have lots of tools, lots of training, lots of assessments about safety and risk. I would argue the same about permanency. We have entire pieces of federal legislation that are completely designed to achieve permanency for children. We have mechanisms in place. We have legal time limits on how long a child can stay in foster care, for example. We have a huge mechanism that promotes permanency for the children that we serve, these very vulnerable children that we serve. But well-being is so much more fluid and less often considered in this space. It's almost kind of like we see, safety as that first thing, which, as it should, and then we kind of see permanency, and then well-being is, well, like if we can get to it, if we have time, if there's space, if there's resources for it. So what I argue is that we should elevate well-being to the same level and of critical importance as safety and as permanency. And the reason being is everything we just learned in that video, because when we disregard well-being and preventing future trauma, maybe not physical trauma, but emotional trauma, and we don't put a child on a pathway towards resilience, we are potentially setting them up for future doses of adverse childhood experiences. And we also might be setting them up for pretty significant health implications in the future. So I think that we have to be really, really mindful of that. So in child welfare, how can we apply the evidence from the ACEs, from the study, to our practice while operating within the boundaries of law, of best interest principles, and of child welfare practices? And I know that we have some folks who don't work necessarily in the court system. So think about this within your own practice. What could we be doing? So I'm going to go through a couple of examples. So this 2-year-old child is going home. That's the plan. The parents have completed every single task on their case plan, everything the court and children's services and CASA and everyone involved has asked them to do. They've done the required number of counseling sessions with some progress. They have 3 months of sobriety as evidenced by clean drug screens and reports from counselors. They've secured stable housing. But the professionals involved in the case, so maybe CASA, caseworker, attorney, counselor, teachers, kind of all know in their guts, I'm putting that in air quotes, that it will just be a matter of time before that child enters foster care again. Now, how many of you have had an experience like this where you're kind of saying, well, yep, I'm seeing some hands and nods, absolutely. So kind of saying, well, yeah, everything's done, but we don't feel good about this. Like we feel like it's just a matter of time before we see this child, come back in front of us or come back into care or something like that. So it is important, before I talk a little bit more about this, is that I am not suggesting that children shouldn't be reunified. That's not what I'm suggesting at all. But rather, what I think we should be doing is looking at how can we strengthen that family, right? They kind of, completed the framework that we typically expect of a family, but how can we strengthen that family and that, the parents' protective capacities and parental capacities to support a successful and permanent reunification, right? That's safety plus permanency plus well-being. We kind of have to check all the, we have to have all the pieces of that. So my question is, should we be openly discussing with the family and, in court or certainly with the parents, our concerns about recidivism? That's where a child goes home and then kind of comes back into care, or a case is reopened. I think we should. I think we should be having, when we have this feeling in our guts, is really thinking about what is it that's informing our guts, right? What are the pieces of evidence or the observations that we have that are leading us to have that feeling in our deep down in our bellies somewhere? And let's work on kind of naming that. And so if we say to the family, I'm really proud that you've completed all of the counseling. we're all really worried that the situation that led to the removal is going to come back together again, and we're going to be back in the same position. What do you think is going to be different this time? What, maybe even talking through what are some of those early indicators when things really deteriorated, and talking to families about this and talking to parents about this. And again, I'm not saying that we shouldn't reunify, that this 2-year-old shouldn't be going home, but I think that we need to take the next step beyond just us feeling a little weird in our bellies about this child going home, and really look at addressing and talking about and creating a plan for those whatever it is that we've observed that have caused us to have that gut feeling. Because when we say, and I know, and I've said this and I hear it said all the time, but when we say it's only a matter of time before the family gets involved again or before the child's removed again, what we're really saying is it's just a matter of time before this child experiences more trauma. So what can we do to try and reduce that dose and help the family understand and avoid that next dose of trauma? Here's another example. This 15-year-old has been in foster care for 10 months. He attends counseling every week, equine assisted therapy bi-weekly, individual visits with each parent because the parents don't get along with each other. So he visits with mom and then he visits with dad on a different day. He visits with his caseworker, his CASA, of course he goes to school, all of these things. So his routine largely consists of school, foster home, visits, counseling, more visits, visits with service providers. So my question is, what's wrong with this picture? What's missing? And does anyone, recognize this schedule and any child that, teenager in foster care that you work with, right? There's all kinds of stuff there. There's not a lot of adolescent time there, not a lot of peer time. One thing that I always bring up that I'm always a little scared to bring up is, does this young person have a cell phone or social media or have a way to connect with his peers? And I know we all have different feelings about social media, about kids on social media and, cell phones, all of these things. But I do think we need to acknowledge, or at least recognize, that it's how youth and teens socialize in this modern day. So what are we doing, if a cell phone or social media isn't a good idea, what are we doing to promote those peer-to-peer connections? What are we doing for that? Because we know that creating connections is a building block of resilience, which helps people heal from trauma, right? And it helps them face any future adversities that they experience. Are we thinking about extracurricular activities, sports, just social time, just, hangout time with friends? What are we doing along those lines? So, and I'm going to check the chat here. I want to make sure I'm not missing anything. Yep. Yeah, so great. I hope everyone is watching in the chat because everybody has really good context there. Really, really good comments there. So the reason I include this particular example is because I think, I kind of think in addition to safety and permanency and reasonable efforts, all those things, I think that we have a responsibility to build healthy, joyful, fun experiences for youth and teens in foster care. I think we do. I think it's important. And I think it relates to what we know about adverse childhood experiences, because it's one of the pathways towards healing, along with, therapy and all of those things. I'm not, not even getting into the clinical side of things. The other thing I ask a lot is, does this young person, this teenager in foster care, does this youth have the opportunity to engage in healthy risk-taking? And I know when I say risk-taking, like everyone freaks out a little bit and gets nervous of what we're promoting risk-taking. But actually risk-taking, healthy risk-taking, is an important part of adolescent brain development. We need to do it to learn. That's actually how we build brains. So I'm not saying that we should say, hey, let's go drop him off, at the well-known drug dealer corner and see how things go with his risk-taking. Instead, risk-taking, like volunteering to lead a project at school, asking someone out on a date, all those types of healthy risk-taking that someone might take, putting his name in the ring to be the class treasurer. Those kind of healthy risk-taking actually help build brains. but we often take away those opportunities for young people in foster care because of safety and permanency. Same thing with like getting a job, going out and applying for a job and putting yourself out there and facing the risk of maybe not getting the job. That's a healthy risk that we, need to figure out a way to promote. So thinking about things in that context, and, thinking a little bit bigger than just kind of what's in front of us right now. And I know a lot of you've all been doing this for a long time. So when you read these little examples, you probably have a million bells going off of ideas and thoughts and things. So know that these are just little snapshots to hopefully clarify some of the concepts that we're talking about. One more example. This is a 9-year-old who's in the permanent custody of Children's Services. So parental rights have been terminated. The case plain goal is adoption. But she's been in and out of foster care for most of her life. She is chronically constipated to the point of multiple episodes of impaction. So it's definitely a pretty serious medical implications. Her foster parent has taken her to the doctor, and she's on a special diet. She's taking daily stool softeners, the occasional laxative to help regulate digestion, all the usual stuff. She's continuing to experience constipation, however, and sometimes even refuses to go to the bathroom because bowel movements are painful. I just realized a lot of you are probably eating lunch. I apologize that we're talking about this over your lunch break, probably. But the foster parent reports that when she does go to the bathroom, she's often tying up the bathroom for a really long time, kind of a problem in a full foster home with lots of busy kids. So in this situation, what's our responsibility here? My first question, if this were a CASA case and CASA was involved, my first question would be, have we talked to the doctor directly about adverse childhood experiences? Obviously, I didn't put any history. This is just a made up child. I didn't put any history on there to know, but I'm, kind of making the assumption that this is a child with, significant ACE score. Have we had a conversation with the doctor about that? And have we considered a more multi-pronged approach to supporting this child? Have we considered, as part of the treatment of this, or as part of the advocacy in this realm, emotional support? Have we, obviously we're already kind of looking at medical treatment. Have we looked at other habit changes? It sounds like there a little bit there's kind of a change in diet. Have we addressed with, and if this is an issue, have we addressed with the foster parent or with the school about not putting time limits on the bathroom, because maybe that's just extra pressure going to the bathroom, but really looking at it as a little bit bigger of an issue other than just, maybe eat a few extra apples each day or add some fiber or whatever it is, but really taking a step back and trying to get to the bottom of it. And especially things like this, I notice child advocates often have to be really persistent when we're looking at issues like this, because this is a well-being issue. This is not at the same level as safety and permanency. So you have to be a little more persistent when we're talking about these kind of day-to-day type things. So, and that's where I really feel like the healing from trauma and the reduction of future doses really fits. Of course, it fits with safety and all of those things too, but I think we need to pay a little bit more attention to a child's well-being and how we're supporting them in that way. So I know we're moving fast through these examples, and I'm sure all of you probably have your advocate brain on and you just want to grill me about all these questions about these 3 children that I've shared stories about. But we're going to move on since we are going to run out of time. So just a few tips, and these things are things you might already be doing, and this might validate and reinforce some of what you're already doing. And this is not an exhaustive list, but I think we can do a few things to kind of level up our work, like I said in the beginning. I think that we need to get into the habit of openly discussing trauma and adverse child experiences, and we need to ask therapeutic providers about it. I can't tell you the number of times I've talked to a child's counselor, and when I ask them, what's the goal in counseling, and they would say, well, it seems like there's some behaviors, happening in the foster home. So that's what we're really working on right now. Incredibly valid, 100%. Yes, let's address that. And then I'll say, okay, so what do you know about the child's history? And they'll say, well, we didn't really get much history. So one thing that I am often doing with my role with the court is making sure that the people helping the child have all of the information that they need to do a good job at it. So, really making sure that we're having those kinds of conversations. I think anyone who makes decisions or interacts with that child should have an understanding of their specific adverse childhood experiences. And we definitely need to be looking at each decision or each recommendation or each referral through this lens, especially decisions that have those more long-term implications. I certainly think that we need to consider not even just current, but also future health a factor in the way that we look at safety, permanency, and well-being. Yeah, and again, there are some great perspectives in the chat, so I hope you all are like looking in the chat and connecting with one another. The other that I think we can do, particularly if you work in a court setting or in a court system, is to start having really open conversations about the implications of recurrences of abuse and neglect. Because so many times we almost dance around that issue when we're case planning or when we're reviewing cases. I think that we should be explaining ACEs to parents that we work with, in a way that they can understand, and not in a judgmental way. We're not judging them because their child has had an adverse childhood experience. But we should be empowering and supporting them and partnering with them to help minimize and avoid future doses of trauma. And I think we have to do that by helping them understand it. This just isn't just the court or children's services or a counselor or a teacher coming in to tell them that they're not doing a good enough job parenting their children, but really partnering with them and educating parents about what this means. Because I haven't really met a parent who says that they don't want their child to have the best chance at health or to have the best chance at safety in the future. I haven't met many parents who wouldn't be supportive of something like that, of a goal like that. So I think if there's a way that we can open those conversations, I definitely encourage you to do that. Those are just four things that I like to inject into the practice that I do. Other just little food for thought pieces is this one. I work a lot with foster parents, but does the child's foster parent understand ACEs in general? I think most foster parents are getting training on trauma and ACEs these days. So a lot of foster parents I talk to already have this background, but maybe if they're newer or they haven't had it lately, maybe sharing information with them about it. And then kind of the implications for this specific child, making sure that they understand it, because we all know foster parents and kinship caregivers are the ones that are more likely to be having those one-on-one conversations with a doctor. So we want to make sure that foster parent has the information they need to get that child the best care. And this one is a little bit of a hot button, and sometimes when I bring this up, but do we think about the fact that we are potentially adding doses when we make decisions based on parent compliance rather than child best interests? So a lot of times we will make a decision in court based on, did the parent do something? Not necessarily, is this in the child's best interest? So I say this often for those of you that have been in my trainings before, and certainly the Athens County folks, but center the child in every decision and every conversation, particularly if you're a child advocate or a child serving professional. It helps us stay focused. And then, do we view high level efforts, so these above and beyond efforts to facilitate parent-child visitation, do we view that as enabling the parents, right? Where, the parents haven't done what they said, but we're still haven't done what they're supposed to be doing, but we're still letting them visit? Or do we look at that as maintaining important connections for the child? The reason we do parent-child visitation is for the child. It's important for the child to have connections with safe relatives, to have safe connections with those relatives. So just kind of food for thought, a different way of thinking about it. And then, do we look at every placement change as another dose? Because it is. And sometimes the placement change has to happen. But the adverse childhood experiences that result from our very interventions that help keep kids safe can have similar implications on health outcomes as those that result from abuse or neglect. So I'm not saying that we shouldn't do those interventions. Sometimes we have to do those interventions, but I think that we need to recognize that sometimes our interventions add another trauma dose, in the same way that the child experiencing abuse again could, or maybe not the same way, but in a similar way. So I think we have to think about those types of things. And, you know, I would love to say that we could just avoid all of these doses forever, all of these hardships forever. I know that in reality, sometimes these things are going to happen. So if we look at it as another dose and we plan around it as if it is another dose of trauma that we know is coming, and we plan around it and support the child and have, you know, therapeutic supports, we have our, you know, all of those connections that are so important, and have a good plan in place, then we can maybe control the impact and minimize the impact that that dose will have, because we're able to plan for it a little bit more. So I think that's another advocacy piece, is really, you know, looking for opportunities to slow processes down, like those crisis processes down, so that we can make planful decisions when possible. I know sometimes things happen very quickly and they have to, but kind of food for thought, something to think about. So we have just a few minutes left. And like I said, I'm going to stay on for up to the next half hour. So if you have a specific question or want to talk a little bit more, I'm going to stay on afterwards. But my challenge to all of you, this has been a quick hour that we've been together, so we didn't really get to dive in as much as I would hope to. But to commit to learning as much as you can, consume as much content, as much research, as much information about trauma and ACEs as you can, learn as much as you can. And this, you know, research is not just, it's not historical research. It's not just something that happened and that's the way it is. It's going to continue to evolve as the world changes, as data points change, as just our children's experiences, right? If you think about, you know, a child born, you know, having an experience in the 2010s is very different than a child who had experiences in the 90s, just because the world is different. So, you know, the information and the best practice should constantly be evolving with our changing world. I challenge you to ask about and start conversations and consider ACEs in every recommendation, every assessment, and every decision that's made. And don't treat it as like a box to check, but really think about how you can inform your practice through this trauma lens. How can you truly be trauma informed rather than just being trauma aware? And then do not treat safety, permanency, and well-being as isolated concepts. You know, I kind of had those in that overlapping diagram. I've often also heard them described as like a three-legged stool. So really thinking about those things all together and elevating well-being to the same level of importance and priority as safety and permanency. Yeah, so Becca in the chat recommended a really good book. It's What Happened to You. That's by Dr. Bruce Perry, who does, if you're looking for someone to follow related to trauma, I definitely recommend following him. But it's him and he and Oprah did that book. And there's even a couple of videos where they've talked about the book a little bit. So I definitely recommend that one. Another one I recommend is The Body Keeps the Score, is a really good, relevant book on trauma as well. So that takes us right up to the very end of our time together. Within the next hour or so, be checking your email. You will get a link to a training evaluation along with the slide deck and links to a couple of the video and things like that. So some training resources. The training evaluation is how you get your training certificate. So once you complete the training evaluation, and we do appreciate your feedback because we like to be responsive to what you all need from us in terms of training. At the end of that, we'll ask you to affirm that you completed the pre-reading. We kind of work off of the honor system, and then you'll get your training certificate mailed. It'll be next week sometime that you'll get your training certificate emailed to you. Just a few things, if you want to do some future learning, these hot links will all be in the information you'll get in the email. I have the original study if you want to read that, and then that Kaiser Permanente ACEs study. That's the really big one that kind of informs a lot of our work now, as well as some other promising practices and guidelines that might be useful to you. So you'll get the links to all of those. I just want to point them out. And then if you are a super nerd like me and you want to read some of the peer-reviewed articles, you'll also have links to all of those. These are some that I think are really interesting and really get you thinking in a different way. So you'll have the links to all of those as well. So you're going to get lots of goodies in your email. And then finally, please stay connected to us. I know you all found our website. That's how you signed up for this training. We post all of any training that's open to the public, we post on the website. We're also pretty active on social media, and we post information about our training and just this kind of stuff. So we hope that you will engage and follow us there on social media. But with that, I know that you all have a lot to do with your time, so I appreciate that you decided to spend this last hour with me. And I'm gonna go ahead and stop sharing the screen and stop the recording. And then I will certainly stay on the line for the next half hour in case anyone has any specific questions or wants to talk to me a little bit more. But thank you all.